So today we are going to discuss on cardiorenal syndrome. We know there is bidirectional link between dysfunction of the heart and dysfunction of the kidney. Heart dysfunction and kidney dysfunction. There is bidirectional link. So acute dysfunction of the heart can lead to acute dysfunction of the kidney, or chronic dysfunction of the heart can lead to chronic dysfunction of the kidney, and acute or chronic dysfunction of the kidney can lead to the acute or chronic dysfunction of the heart. And in secondary cardiorenal syndrome, acute or chronic systemic disorders like say diabetes mellitus or sepsis that leads to dysfunction of the both heart and kidney. So how can you say that there is bidirectional link between heart and kidney? What are the evidence regarding this? So regarding that, I would like to tell you that patient with CKD have increased risk of both atherosclerotic cardiovascular disease and heart failure. And cardiovascular disease is responsible for up to 50% of death in patients with renal failure. And several studies have shown that mortality is increased in patients with heart failure who have reduced GFR. Mortality is increased in patients with heart failure who have reduced GFR. So these points suggest that there is bidirectional link between the heart and kidney. Now we are going to talk about definition of cardiorenal syndrome with this background. So in 2004, National Heart, Lung and Blood Institute released one report, and they have defined cardiorenal syndrome in that report as a condition in which therapy to relieve congestive symptoms in a patient with heart failure is limited by decline in renal function as manifested by decreased GFR. So now let me write on this board for you. So a condition in which therapy to relieve congestive symptoms is limited by decline in renal function. Decline in renal function manifested by reduction in GFR. And Ronco and colleagues, they classified cardiorenal syndrome into 5 types. So now let's talk about type 1 cardiorenal syndrome. So according to Ronco and colleagues, what is type 1 cardiorenal syndrome? Acute heart failure results in acute kidney injury. Type 2 is chronic heart failure leads to progressive CKD, chronic kidney disease. Type 3 is acute kidney dysfunction. This is opposite of this. Acute kidney dysfunction leads to acute heart failure. Acute kidney dysfunction cause heart failure. And type 4 is primary CKD contributes to cardiac dysfunction. Primary CKD contributes to cardiac dysfunction. So cardiac dysfunction may not be only limited to the heart failure. It may be in form of coronary heart disease or heart failure or arrhythmia. Okay. And regarding type 5, I already talked previously. It is secondary cardiorenal syndrome in which acute or chronic systemic disorders can cause dysfunction of the both heart and kidney. Like I already told you regarding in sepsis, diabetes mellitus, it can be like that. Okay. So after talking about the types of cardiorenal syndrome, now let's talk about prevalence of cardiorenal syndrome. So how often do you see cardiorenal syndrome in your practice? So several studies have shown that prevalence of moderate to severe renal impairment, moderate to severe renal impairment, GFR defined by GFR less than 60, this is found in 30 to 60% of patients with heart failure. So why is this big range from 30 to up to 60%? Because I had already told you that several studies. So in different studies there is different prevalence, but the range is from 30 to as high as 60%. So this is high number. 60% of patients with heart failure have GFR less than 60. So you can see the prevalence. And patients who are undergoing treatment for acute or chronic heart failure frequently develop increase in serum creatinine, which fulfills the criteria for type 1 or type 2 cardiorenal syndrome. And in different series, 30% of patients developed increase in serum creatinine greater than 0.3. And in one report, 24% of patients with heart failure had increase in serum creatinine 0.5 or greater. Now let's suppose I am giving you one scenario. An elderly male presents to your clinic and he has history of heart failure admission 6 months back. 6 months back, and in past medical history he has history of diabetes mellitus, uncontrolled hypertension, and this time he has presented to you in acute decompensated heart failure. And at time of presentation his serum creatinine was 0.9. So this patient you are planning to admit him. He was admitted 6 months back, and this time again you are planning to admit him for decongestion and optimization of his medical therapies. So can you tell what is his chance of developing cardiorenal syndrome during this hospitalization? Obviously you can see his creatinine is not deranged during that time of presentation, and what is the chance of his developing into cardiorenal syndrome while you hospitalize? Can you predict it? So before telling the answer of this question, let me tell you that obviously there is risk of cardiorenal syndrome. During the first, there is high chance of developing during the first 3 to 5 days of hospitalization. And what are some of the risk factors? So some of the risk factors for worsening renal function during admission are prior history of heart failure and diabetes mellitus, uncontrolled hypertension, and at time of admission, if serum creatinine is greater than 1.5. So one is at creatinine, elevated creatinine at time of admission. One I told you history of heart failure or diabetes mellitus, history of uncontrolled hypertension. So if these parameters, if you see in patients, then there is chance of developing high chance of developing cardiorenal syndrome in that patient. Now next question, 65-year-old male with heart failure with reduced ejection fraction presents to your office, and his serum creatinine at time of presentation was 1.7. So in this patient, can you tell me whether his renal, this increased creatinine, whether it is due to his underlying renal impairment or whether it is due to cardiorenal syndrome? What do you think? Whether it is due to underlying renal disease or cardiorenal syndrome? Can you tell me at this point? No. And it is important to distinguish whether it is due to underlying renal disease or whether it is cardiorenal syndrome, because treatment will be different, prognosis will be different, so it is important to distinguish. And to simplify this matter, let me tell you that there are some findings that suggest underlying renal disease. Underlying renal disease. So can you tell me what are the some of the findings you can check that supports the notion that he has underlying renal disease? So one is significant proteinuria. Significant proteinuria. Active urine sediment. Active urine sediment. Hematuria. Hematuria with or without pyuria. With or without pyuria. Cellular cast. Cellular cast. And on radiological evaluation, small kidneys. Small kidneys. So these, if you find these findings, if you see these findings, you can say that patient may be having underlying renal disease. But let's suppose the patient has normal urine analysis. So though this rule out that patient does not have underlying renal disease and it is only due to cardiorenal syndrome. Obviously no. Because there are some variety of renal diseases, like one may be nephrosclerosis, obstructive nephropathy, where you get normal urine analysis. So if urine analysis is normal, you cannot tell that it is only due to cardiorenal syndrome. There are maybe other findings, but I told you some supporting findings that supports that it is maybe due to underlying renal disease. Okay. And heart failure is a cause of prerenal azotemia. Prerenal azotemia. Although evidence suggests that worsening renal function due to heart failure is not solely related to decreased cardiac output and frequently occurs in the setting of volume overload. Now I am going to ask you another question. A patient with heart failure and he presents to you with features of congestion. At time of presentation, his BUN creatinine was 30. So you think that he has prerenal azotemia. So this is due to the volume depletion. And although he has presented with congestive symptoms, if I give diuretic to him, his renal function will be more aggravated. There will be worsening of renal function. So I should not give diuretic to him. So if you are thinking like that, you are not thinking correct. Because elevated BUN creatinine in a patient who has congestive symptoms should not deter you to start decongestive therapies. Okay. And now I am going to talk about another lab parameter which is called sport urinary sodium. Sport urinary sodium. So you get urine sample and you check the concentration of urinary sodium. So why it is important to know this? Why it is important to check urinary sodium in heart failure? In heart failure there is decreased cardiac output which leads to decreased renal perfusion. Which leads to activation of sympathetic nervous system and rash, and both of which promote sodium water retention. So if there is sodium retention, what will happen? Urinary sodium will be low. So in patients with heart failure, urinary sodium will be less than 25 because of the compensatory sodium retention due to activation of the RAS system. However, if patient is on diuretic therapy, so in those patients urinary sodium may be high because the sodium channels are blocked and urinary sodium may be high. Nowadays, evidence is growing that urine sodium profiling, this can predict short-term responsiveness to IV loop diuretic in patients with heart failure. Urine sodium profiling can predict short-term responsiveness to IV loop diuretics in patients with heart failure. So if you get low urinary sodium in a sport urinary sample, what does it suggest? It suggests that there is diminished diuretic response. There is diminished diuretic response, as well as this patient has increased chance of hot failure readmission and increased cardiovascular mortality. Increased cardiovascular mortality. Let's suppose you give IV furosemide 40 mg to a patient with heart failure who has presented with congestive symptoms. IV furosemide 40 mg, and after 2 hours you check a sport urinary sodium, and let's suppose the urinary sodium is 10. So what we can infer from this? You can infer that he is not having sufficient diuretic response, because if there was sufficient diuretic response, this should have increased. No? And but if let's suppose urine sodium is sport urine sodium is 7, you can say that this is responding to diuretic, and in those patients you can increase the dose of diuretics to relieve his congestive symptoms. So you can see that how handy this tool is, a sport urinary sodium, that can help you to whether to increase the dose of diuretics or not. Okay, and what is the definition of insufficient diuretic response? Insufficient diuretic response. So this definition was given by European Society of Cardiology, and they have told that a sport urinary sodium less than 50 or hourly urine output less than 150 ml during first 6 hours. This is the definition of insufficient diuretic response. So after talking this, now let's talk about pathophysiology of cardiorenal syndrome. The pathophysiology I like to demonstrate with a pictorial diagram. So let's suppose this is heart, and this is the superior vena cava opening in the right atrium. This is the right ventricle, this is the left atrium, and this is the left ventricle. So you know, in right heart failure what occurs? Right heart dysfunction. Right heart dysfunction. In left heart failure what occurs? Left heart dysfunction. Or if in both heart failure, both side of there is failure in both sides, then both right and left heart dysfunction. So in right heart dysfunction what occurs? Due to dysfunction there is increase in central venous pressure and increased congestion, and increased congestion leads to increased renal venous pressure. Increased renal venous pressure. This leads to decreased GFR. Okay. And in left heart dysfunction, you know, there is decreased cardiac output, stroke volume, which leads to activation of release of vasopressin and activation of sympathetic nervous system, and RAS is activated. This leads to vasoconstriction, sodium water retention. Sodium water retention occurs, and this leads to decreased renal perfusion, and ischemia. No, ischemia. This leads to decreased GFR. And in decreased cardiac output, what occurs? There is release of natriuretic peptides. Release of natriuretic peptides. Bradykinin, prostaglandin, and which leads to vasodilation. Natriuresis, and this leads to decreased GFR. So from this figure, so what are the headings under which we can describe the pathogenesis of cardiorenal syndrome? One is right heart dysfunction leading to increased renal venous pressure, and another is neurohumoral adaptation leading to decreased renal perfusion. So let me write it. Right heart dysfunction dysfunction, increased renal venous pressure, and neurohumoral adaptation, leading to decreased renal perfusion.